how this funding should be used, could be used, how you expect it will be used.
Pay bills and increase services and hire more physicians and hire more staff.
The government just released news that they're going to be distributing $50 billion.
What I fear, can happen in this kind of an environment is that, as you're saying, the money goes to where they see the big cost centers.
So you've got $500 million covering the losses of health centers that are $900 million. So we're still $400 million short.
We've established that the $50 billion is not enough, but something's better than nothing.
Welcome to the Next Orbit podcast, where connecting healthcare's data is the next frontier. We take you inside conversations with policymakers, healthcare leaders, disruptors, and visionaries who are pushing boundaries in a system that resists change. Explore how modern technology can remove barriers and improve care at scale. It's about ditching inertia and building smarter. For insiders, innovators, and anyone ready to navigate what's next, this is your launchpad. Here is your host, Ben Wade.
Hi, welcome to another episode of the Next Orbit podcast. Here with Mike Hunter today, my co-host, and we're on site together. We're here to talk about rural health transformation and the $50 billion that the government is injecting into rural health to transform both with technology and also financially to help some of these rural health centers that have been struggling with recent Medicaid cuts. So really, we're thrilled to introduce our guest today, who's held many roles across rural health, from physician to professor to CMO, CEO, and now he is currently the president and CEO of Community Health Clinical Research Corporation. Looking forward to talking with you a little bit more about that. With that, let's welcome Dr. Vincent Thompson.
Thank you. Yeah, excited.
Thank you, Ben. Thank you, Mike. I'm glad to be with you.
For our listeners who may not be familiar, the government just released news that they're going to be distributing $50 billion, which will be spread out across the United States over the next 5 years, $10 billion allocated annually. This is coming right off the heels of a lot of big beautiful bill.
One big beautiful bill.
One big beautiful bill. A lot of cuts to Medicaid, and so I think there's some promise to this this fund that they're putting into, I guess specifically for rural health is what it's supposed to be for.
Entirely. But
want to have a little bit of a discussion there with you, Dr. Thompson. I've run the numbers, and I don't know if 50 billion over the next 5 years is gonna put a dent in the 900 billion that they're expected to lose over the next 10 years, but maybe with some advances in technology. So want to get your ideas on how this funding should be used, could be used, how you expect it will be used, and what kind of benefits we can expect to see across rural health in the United States.
Well, I think that the real problem is, one, it's not enough money. It's barely a dent into what they're expected to lose just from the one big beautiful bill. With the one big beautiful bill, there's going to be a loss to our safety net providers, probably somewhere between 5 and 15% of their Medicaid dollars is going to be lost. So you're talking about, for every clinical site, not talking hospitals, but for every clinical site, the offices that are out there serving the people day to day, they're going to lose about $500,000 a year. So you're talking 9,000 sites losing $500,000 a year. So you can do the math. You're at right there, $450 million a year right there, just in the rural health sites that they're losing. So when you start talking about 10 billion, now you got to talk about the rural health centers, the community health centers, the rural health hospitals, the regular hospitals, and everybody that's going to pick up the slack, because when they remove 15% of the patients from the Medicaid rolls, they're all of a sudden going to become uninsured patients. So not only are they going to lose the money that they were getting from them for paying for their services, they're going to have to still pay for the services to cover them as uninsured patients. So it's a double whammy. So now you're up to $1 billion a year just because of the Medicaid cuts, not to mention the 340B cuts and the other areas which were removed by the one big beautiful bill. Now if you're talking about distribution, the way that the bill's written, most of your frontline health centers are not going to be able to touch that money. It's going to end up going to the rural health hospitals and to the other hospital systems because they're going to be the big boys. They're going to have the people that are going to have the stronger lobbyists, and they're going to have the technology behind them that's going to allow them to be able to access that money to do the things that are listed in the bill. So is it a lot of money? It's a lot of money. Is it going to a good cause? Yes, it is. Is it going to get distributed the way that it probably should? Probably not. It's going to get eaten up really quickly by technology, by advancing AI, and it's not going to actually get to serving the communities that need it the most.
The money was supposed to be split up into two pools, right? There's 50% was supposed to be divided equally among the states who, I guess, applied and were approved by CMS. The other 50% was to be distributed based on rural population, the number of healthcare facilities a state may have in rural regions, the financial vulnerability of hospitals in those areas. So, I don't think all of the components that are known that go into how that other 50% is being distributed, but it sounded to me like half of that $1 billion that a state may get could be going into one of those larger projects with one of the larger hospitals that you were talking about. But the other 50 should technically be used to prop up those rural health centers that are struggling. Did you understand it the same way, or did we have a
I
different?
understood that it's going to be going to the states, and then it's supposed to be used in that way. But my guess is that it's not going to do what it's supposed to do. You're looking at between 8 and $12 billion loss per year just in the Medicaid patients. So if we're saying that you're going to take, so now we're saying half of the money. So now you're down to, what is it, 23 billion dollars going into the states, and now we're going to divide it into 50 states. So now you're talking 500 million to each of the states, and each of the states are going to be losing probably 900 million because of the Medicaid cuts. So you've got 500 million covering the losses of health centers that are 900 million. So we're still 400 million short because you had that, like I said, you take half of the 56 billion is what, 28 billion, and then now we're going to put it into 50 states. So now you've got half of that. So you have basically $500 million going to every state for funding the health centers, and you're about 400 million short for each state.
Yeah, even if the money was all allocated to the facilities that need it the most, there would still be a large deficit. And then on top of that, what you're saying is that, although states have some discretion on how those funds are going to be used,
Right.
it could be technology, telehealth, different
Right. I
interoperability.
think what's going to happen is that the rural health hospitals that are in those areas is where they're going to end up putting the money, because they're going to want to fund the emergency rooms, and the surgical departments, and the trauma departments, all the areas that are covering most of what comes into the hospital systems. But the problem is that doesn't cover the day-to-day people. That doesn't cover people that need their health care for their diabetes, for their hypertension, for their metabolic syndrome, for their children, for immunizations. You're not looking at things of that nature. They're looking at big picture items, and they're looking at big ticket people they think can cover more access. when you're talking to politicians, they think, oh, the hospitals are what are taking care of people. And they forget that it's actually the community health centers and the rural health centers that are seeing people every day, that are taking care of their day-to-day chronic illnesses. And that's where things start to fall through the cracks.
If I could kind of follow up on what you're saying there, Dr. Thompson, I think what I fear, can happen in this kind of an environment is that, as you're saying, the money goes to where they see the big cost centers, but the reality is that what's feeding those big cost centers is the lack of the day-to-day care. So, for example, if I'm a diabetic and I can't get the appointments I need anymore, and I'm not getting medication on a regular basis, and I can't afford that medication, and there's nothing to offset that, then eventually I do end up in the hospital. But that could have been prevented downstream by investing more money in those community health centers, as you're talking about, so that I'm getting the care I need on a daily basis, and I don't end up in an acute situation where I have to, be rushed or rush myself to a hospital to get the care that I now need because of that kind of, cascade of issues. Is that a fair way to look at this? That those are some of the concerns we should have?
That's very fair, Mike. That's exactly the problem. That's exactly where the issue is going to arise. And when they go into the hospital, that acute issue isn't going to be a quick fix. It's going to be a difficult fix. It's going to require an amputation. It's going to require an ICU visit. It's going to require a CCU visit. They're going to have a heart attack. They're going to have a stroke. They're going to need an amputation of an arm or a leg because their circulation has failed in that area. Their kidneys are going to fail. They're going to be in the hospital, and it's not going to be it's not going to be a $100 office visit. It's going to be $100,000 hospital visit.
Right.
So all of a sudden we've multiplied it, over and over again, and that money is now being eaten up quite quickly. Most of the time, it's not even going to be at that level of care, but because the hospital system is going to put it into something other, into new programmings and new ORs and new redesigning emergency departments to better equip more people, and so it's not going to actually go into care, and that's my concern. We say we're giving money for care, and very rarely does it actually go into care. The only money that really goes into care are the grants that they give to the rural health and to the community health centers. And that money gets used pretty much for direct patient care and for doing preventive care and helping to make people healthier and keep them out of the hospital and prevent those big ticket items. But right now, what's happening is counterproductive to the way that the system has worked for 60 years. The rural health and community health centers started 60 years ago under one of the few things that came out of the President Johnson's Great Society, were health centers, and they've lasted 60 years, and they've been the safety net for 60 years. And right now, one of the probably unintended events that are happening because of the One Big Beautiful Bill is that health centers and rural health centers and community health centers are going to be paying the price, and that our underserved patients are no longer going to be having the ability to get as much care that they need to take care of them on a day-to-day basis.
Could I ask one more question?
Sure.
Would you mind, Dr. Thompson? I know you're familiar with the Health Resources and Services Agency, and could you kind of compare and contrast this opportunity versus the grants that come out of the Health Resources and Services Agency, HRSA?
The money that comes out of HRSA, the grants that come out, those grants go specifically to the frontline health centers. So they receive $1 million or $2 million or $500,000, and that money is earmarked directly for the care of people. It's supposed to be spent on taking care of individuals that are underinsured or uninsured. That's what that money is specifically for, the people that fall through. Basically the working poor. They have a job, but they make too much money to have Medicaid. They're not old enough for Medicare. They have a job that doesn't provide them with insurance, but they want to be working. They want to be being self-sufficient, but that self-sufficiency doesn't allow them to afford health insurance because of the high cost of health insurance right now.
Right.
So they can't afford health insurance. They make too much money from Medicaid. They're not old enough for Medicare, and they can't otherwise receive care except by going to a rural health or a community health center, where they pay a they pay a copayment, but the grants that they receive are supposed to take care of those people. Now, right now we have the government shut down, where we haven't passed the bill to continue the grant funding at even the current level that health centers, rural or community, are going to be receiving. So that hasn't been appropriated yet. And the thing that keeps health centers going is that they have an enhanced Medicaid rate. So where your regular doctor may get $11 for a office visit for a Medicaid patient, rural health and community health centers have an enhanced rate of somewhere between $180 and $225 that really sustains them in taking care of their Medicaid patients, but allows them the additional dollars to also fund care of the uninsured patients.
That's very helpful. And I think kind of what I see as a difference, given the things that you're saying here, is that while there is a tranche of money that is set aside to go to frontline care, because it's going to be administered through the state, that will really be determined by the state. Whereas through the work that those programs do at HRSA, they're able to ensure that that goes straight to the community health centers. They can provide that care, both in the rural, you're right, this isn't just a rural thing, both in the rural and in other communities. It seems like as we've looked at the impact of some of the cuts that are coming out of the One Big Beautiful Bill, that it's going to, in some ways, disproportionately impact rural healthcare, which is why then this Congress acted to allocate this money to try to offset some of that impact, because they recognize that as well. So just kind of calling that out as a contrast, because I think that's an important contrast for our listeners to understand if they're not familiar. The Health Resources and Services Agency, HRSA, I know they're kind of a smaller agency, but they do a lot of good work in this community.
Yeah, they do.
So, Dr. Thompson, we've established that the $50 billion is not enough, but something's better than nothing. And so with that said, if you were in charge of your state's fund and you were making the decisions on how those dollars were allocated, what would be your suggestion? And remember, you're talking about $1 billion here over 5 years, half of which will be distributed evenly or amongst your rural health centers, and the other half at your discretion, or at least that's how it should be spent.
I would want the money to go to the frontline providers. I think that we would need to look at the rural health centers, the community health centers that are taking care of people on a day-to-day basis. The hospital systems would want a large chunk of the money, but if we can take care of people on the front line, on their daily healthcare needs, we're going to prevent them from having to go into the hospital for the big ticket items. So if we can have them through their primary care visits, getting their medications, taking care of their diabetes, taking care of their hypertension, then they're going to avoid the heart attacks, the strokes, the amputations, the things that are kidney failure, the things that are going to put them in the hospital in the CCU. So instead of spending $100,000 on a hospital visit, we're going to spend $120 on a primary care visit, and then we can take care of a lot more people with that money that could go to each health center. Put enough money to take care of the people that walk into the emergency rooms on a percentage basis. But if we can keep people out of the emergency rooms, if we can keep them out of the hospitals, and we can take care of them within the rural health centers and the community health centers, then we save a lot of money, but are more efficient with our money, because our primary care doctors and our pediatricians and our OBGYN doctors are taking care of the daily needs of our people. And then we're keeping the country healthier, keeping them out of the hospital and preventing the big ticket items. So efficiency wise, I think that would be the better way to spend the money. So that's what I would do with that money if I was in the state. I think that the state health departments and the local health departments should get together and say, which health centers have the most need? Where are we taking care of the most people that have no insurance, that have the highest risk because of their demographics for diabetes and hypertension and heart disease, and how do we manage those people most efficiently?
Do you think there are any accountability mechanisms in place from CMS? Like how is CMS ensuring that the funding that they're giving to these states is used in a way that's actually going to provide some benefit in the long run?
They've probably come up with guidelines and they're using their standard guidelines. Government doesn't like to reinvent itself, it falls back on what it has. So they're using their standard guidelines on how this money is distributed, and it'll have certain criteria. Having been a grant reviewer for the federal government for 30 years, the guidelines haven't changed in the 30 years that I've been doing it. We still review the grants in the same way, and I'm sure these grants are going to be reviewed under basically the same criteria. So what will happen is the states will have to, in the 3 months that they've had, come up with a plan that fits the criteria of the grant that is being set forth to them to be able to obtain the money from this distribution. And that's basically what'll happen. And then once they get the money, then they'll figure out how to spend it within the confines of the grant that they wrote. Because within 3 months they can't honestly come up with a specific detailed plan of how to spend that money, because they don't look at everything in the greatest of detail. Health centers write their grants every 2 to 3 years because that gives them the time to see where do they need to focus, where in their communities do they need to spend the money, and where do they need what areas of service do they need to provide. So, but for a state to look at the whole state and look at everything in 3 months, there's no way they can survey, and I doubt that they've surveyed all the health centers, that they've surveyed all the state primary care associations, that they've looked at the state rural health associations, and said, how should we spend this money? I doubt that question's been asked. So they're writing a grant, based on the questions that the grantors are asking and saying this is what we'll pay for, and they're going to go back and then figure it out after they get the money.
A question for him, Mike, but while we're on this topic, I know you answered with you would use the money to funnel it to the front lines, the folks, the care centers that need it the most. Does that look like additional staffing? Are there any technologies out there that you would
that gets into what I would like to ask? I'd love to ask
great.
the question if I could jump in,
Yeah.
because you've been working, as you said, reviewing the grants for HRSA and for others for 30 years. As the saying goes, necessity is the motherhood of invention. There's been a lot of thought in that community about how to address the needs of their patient populations and the people they serve in innovative ways with limited funding. And I'm wondering if you've seen any of those that you would want to highlight that, I would say states ought to consider as they're thinking about writing their grant for this. Are there things that you would say are more effective? And I'm thinking, for example, I'll just throw it out there, although it's also at risk right now, is that telehealth has had a lot of an impact, particularly in rural populations, at making care accessible. Are there other things you've seen or anything you'd like to say about that you'd recommend that if, you're working with the state to write the grant, you would say that'd be a great innovation to incorporate?
It's interesting because things come into focus many years after they actually become available. And it takes time to get things into the box. Healthcare, particularly in our rural health centers and our community health centers, tends to be a very tidy, neat box because they have limited dollars to spend on what they do. So they're slow to spend money on new ideas because they know that they have to take care of people and that they need to have doctors and nurses and medical assistants and services that basically let them take care of their diabetes, their hypertension, their heart disease. And when there are innovative new ideas to do things, they're slow to do it without other people doing it and saying, see, we've done it and it worked. That puts them at a disadvantage sometimes because they're always waiting for somebody to do it first. And unfortunately, if everybody's waiting for somebody to do it first, nobody does it for a while. So, we still get grants for telehealth. That particular site is new, but as it being innovative, it's been around for 30 years. It's not innovative anymore, but it's new to that particular health center. And that's where it gets a little bit difficult because grant reviewers have to be cognizant of the fact that not every health center or not every hospital, but depending on where they're located and what rural district they're in and how isolated they've been, has had the opportunity to keep up with technology, even though it may seem, oh, it's been 30 years. But if to them, it hasn't been 30 years because it hasn't reached them to that level. And they haven't had financial wherewithal to move along at the same speed as other health systems or hospitals may have that are more closely linked to bigger health systems or the state and been able to attain funds to jump into the future, if you can say that. Does that make sense, Mike?
It does make sense. And I guess maybe I should have phrased my question a little differently because that's true. That's absolutely right that there is reticence to spend money on innovation that hasn't been proven. So maybe the other question I should have asked is, have you seen things not so much that are innovative, but have been proven to be effective and relatively low cost that might be the right kinds of things for them to consider? So you talked about telehealth. I think telehealth, thanks in large measure to what happened during COVID, has become much more common. But as you pointed out, it had been available for 30 years already. So it wasn't like it was a new invention. It was more like people finally were willing to allow for it and to pay for it and to accept that it could be in some instances as effective as an office visit. And so are there things like that that could be considered for this to help make that money go further, I guess is what I'm thinking.
And Dr. Thompson, one thing I'll just add to that, one thing that comes to mind in particular is, if we've got all these rural health centers that are at risk of closing, does it make sense to invest in something like a AI triage tool for that can be reached by the masses, no matter where you live, and help patients understand whether or not a visit to a facility is necessary right away? That way we're freeing up space in the ER for your more critical visits. Or
well, Ben,
I'm just
now
brainstorming.
you're assuming that the general population is technologically up to date.
Yes.
True.
And you're
And
also
that,
assuming that
you're assuming that your folks out on the farm or out in the rural countryside have a
Fair.
laptop and a computer and know how to
Fair.
even manipulate to do an AI visit with it, and that they're going to even feel comfortable or trust to having the computer diagnose what's wrong with them.
Hey,
They're
I'm not
having a
saying
hard
I
time.
have the answers, Dr.
and on
Thompson.
the clinical side, it's fair to say that also those things, I mean, the reason that medicine is so cautious about adopting new things
Sure.
is because they recognize that moving too quickly and breaking things, as people like to do in the tech world, means lives. It means people die, and it means people are harmed. Yeah.
All fair point.
It's a good idea. I'm sure people are working on it, but go ahead. Sorry.
That's the type of things that the states are going to be talking about because AI is the thing right now. But when you're talking about reaching people with AI, seniors and people that, don't have a laptop or even a desktop or even a computer, that are going to try to do it on their cell phone to have this AI visit that they may or may not learn about. So when we're talking about, new technologies, But many times, like I said, the health centers fall back on old technologies that may be new to them. One of those is mobile health units. We still receive a lot of grants for mobile health units, and we review them. Health centers asking for, or hospitals asking for, Winnebagos to be converted into doctors' offices, put in X-ray machines, mammograms, laboratory equipment, EKG machines, so that we can take the doctors, the nurses, and the equipment to the people they may not be able to go 25, 30, 50 miles to them. And when we were talking about, an AI visit, well, an AI visit, they may not be able to follow up with that. They may be told, well, you need to go to the doctor, you need to come in for labs. Again, if they can't travel to them, it hasn't done it. It's not been of any value. They know there's something wrong with them, and they know they can't take care of it. Where if we can bring the doctors and the nurses and the equipment to them, we can do the lab work, we can do the EKG, we can do the X-ray or the mammogram, we can take care of people. So we still fund things, even though the ideas and the technology are not new. But but specific areas, they are new and they're necessary to make the health system work. And they're the type of things that the money should be spent on, because it's about reaching people. And that's always been my mission, is to reach people and take care of people, not necessarily take care of corporations or take care of health systems, but to take care of people. And if you're taking care of a health system to take care of people, that's good. But if you're using the money to create systems that look good and are technologically, oh wow, they're using AI to take care of 1 million people, but in the long run, those 1 million people learn something but can't act upon it. Is it really of value?
It's a great question. Yeah, I love that.
We've established that the funding is not going to be the lifesaver that keeps the doors open for a rural health center that's already struggling. What are some of the things that these rural health centers can do, these rural hospitals can do, that are hit the hardest by these cuts to Medicaid? How can they prop themselves up and find their own path to financial stability in the midst of all this chaos?
What we're doing right now in my company is we're trying to find alternative pathways for sustainable funding for health centers and for rural hospitals and for small hospitals and the community health centers to become financially sustainable. For 60 years, having been a CEO of a health center many times, and having had every time you go to an event, you have your hat in hand, and your mission is to talk to the senator, talk to the congressman, talk to the philanthropist, and say, hey, we need money to take care of people. How much money can you give me this year? And it's true, though. You talk to your CEOs of your health centers, your rural health centers, your community health centers, your small rural hospitals. Their social calendar is with hat in hand to seek funds continuously, 7 days a week, 365 days a year. And that's what the CEOs worry about. And the real concern with the Medicaid cuts, and they're not really Medicaid cuts, they're restructuring how people are, what they have to do to be in Medicaid. And the problem is the stipulations and the guidelines for the people to be on Medicaid, about 15% of the people aren't going to do. And that's what the problem is. So those 15% of people will be disenrolled from Medicaid, and that 15% will then become your 15% more uninsured and underserved people. So it's a double whammy. Don't get paid for them anymore, but we still have to take care of them at our expense. So it's a double whammy of cost. So what our company has looked at, and what we've done is, myself and my son, and we're both from the health center movement. I've been in the health center movement as you begin for over 30 years. Director of ambulatory services in Buffalo when I first became involved in health centers. The health center on the county property was defunded for fiscal malfeasance. And the federal government went to the university, which controls all the doctors in Buffalo, and went to the county where the health center was defunded at, and said, fix the problem. Well, I was the university doctor at the county, and they said, Dr. Thompson, fix this problem. I knew nothing about health centers, and I had to become an expert in health centers, in HRSA funding, in licensing, and all of the things that went to go with that. And that's how I became involved in the community health center movement. And we built a brand new facility. I obtained a grant. We were doing 100,000 visits the first year we opened the new facility. We were doing almost 200,000 visits the following years. We applied for an additional grant funding. After 2 years, I actually became the president of the Primary Care Association for New York State, which has since become CHCANY's, the Community Health Center Association of New York State. But I was one of the first presidents of it before it was CHCANY's. And then I ended up working for the Bureau for a number of years, opening health centers. And one of the things that I discovered when I was the CEO for was we were living Medicaid check to Medicaid check. You were waiting for that check and hoped that it came by the 15th of the month. So you were able to make payroll and pay the electric and pay the gas and pay the water bill. And many times it came late. And when it came late, you were told to staff, well, you're not getting paid on Friday, maybe Monday or Tuesday. Or so I understand what we're talking about. One of the things that I did when I was at the university was research. So I thought to myself, well, research brings in money. So I called my friends at the university and I said, we need to do research at this health center. Can I get a clinical research coordinator to do the research for us? And they said, well, and I said, well, when I get the money, I'll pay you. They said, well, sure, we're paying for them anyway. They can come and work with you and then you reimburse us. And so that's where the thought process 30 years ago came from, to bring in additional dollars. And we were bringing in, at first a couple $100,000, and by the end of the second year, $1 million. And we were being able to pay bills and increase services and hire more physicians and hire more staff without having to worry about grant dollars or worry about the Medicaid dollars or having to go out to every party on every weekend that was going to be on the social calendar of the state representatives and the federal representatives and senators to be there to ask for money, because we were bringing in additional revenue that was paying for the services, and we were sustainable without having to have hat in hand. So when I was opening health centers, I recommended that those health centers that I was working with to establish that if you can do research, do it. So a number of health centers did do it. So now here we are 30 years later, and we were looking at, well, what are we going to do if something happens with the new administration unintentionally that may hurt health centers? And here we are, the one big, beautiful bill passed. And not intentionally, I don't believe the congressmen or the senators even thought of what they were doing was going to negatively impact the safety net. But as a result, here we are with 9,000 rural and community health centers all in a panic because they may lose 15% of their revenue in the next 3 to 6 months. And once that happens, they're not going to know how to make it up. So we created, and just as an aside, the National Association of Community Health Centers did a research study with Deloitte in 2023 that said, we believe research should be part of every health center's scope of practice. So they did a study to see who was doing research and why the other ones weren't. And they found that basically there was a number of barriers that prevented 87% of health centers, rather rural or community, from doing research. And they were very easy. They were money, they were people, they were time. And then there was a whole bunch of other smaller barriers to that happening. So when we created this organization, Community Health Clinical Research Corporation, we created it by using that study and saying we need to remove these barriers so that rural and community health centers can do research, get the benefit of the research for the patients, the innovation, the sustainability, the new medications, and as well as being able to attract physicians that can want to do more than just care day to day, being able to do some academic work, do some research work, possibly be published, do presentations, and also have the sustainable revenue stream that can go into the health centers and not be dependent on grants or on the politics of the day. And that's where we came from. So what our goal is to realign private sector funds, basically the $56 billion that go into clinical research every year, into the public sector by having community health centers step up and be part of the research program that happens nationally every year. And the pharmaceutical companies spend $56 billion every year. And most of that money goes into paying for private research centers or for private doctors' offices to do research. Well, if we can have health centers doing it, and we can and the things that it does that are a benefit is the diversity is often lacking in the research that the FDA is doing. They're always on the doctors' offices and the pharmaceutical companies to get diversity because they want to make sure that the medications are developing work in all populations, not just in a single population. So they need the diversity of experience in the studies. So by having health centers be at the forefront of doing research, we're making sure that the medications that are being developed work on all peoples, not just young white college guys, young white college women that go in and get paid for doing studies in clinical research sites. And we're bringing innovation to the health centers. We're bringing new technologies to the health centers, and we're bringing medications and the ability for patients that may otherwise not be able to be on these medications to be on them for not only the length of the study, but many times they provide them for time after the study for 6 months, a year, 2 years until they fully come to market. And they'll allow those patients to stay on the medication to take care of themselves. And when you have your under and underserved patients, all of a sudden being able to receive care and studies and laboratories and EKGs as well as their medication because it's being subsidized by the pharmaceutical industry, wow, that's a win. When we're not spending the grant dollars and we don't have the enhanced Medicaid dollars to pay for them anymore. Or there we have a sustainable revenue source to provide care for our uninsured and to sustain the safety net. And we're bringing private industry into the public sector, which kind of falls in line with what the current administration likes to see anyway. We're crossing over things and making the private sector work with the public sector to take care of it, to take care of our people.
Yeah, well, you're solving one of the problems that I hear most in clinical research, which is that facilities don't have the manpower to plug in all the additional data to participate in these. And from what I heard, Dr. Thompson, is it some staff augmentation that you're doing? Are you putting bodies at these sites, or is it all remote?
Oh no, we're putting bodies at the sites. We're doing a number of things. One, we're providing all the administrative and logistical work. The people at health centers, the administrators at health centers, the doctors at health centers, they may not have any experience in research. We're going to do all the logistical work for them. We're going to do the budget negotiation, the contract negotiation. We're going to facilitate putting them on to the platform to be able to have the pharmaceutical companies know what indications they are best suited to be able to take care of and which studies are best suited for their particular population so that they're offered studies that benefit their communities. We're going to be putting a clinical research coordinator, not a new person, someone that has at least 3 to 5 years experience at their location. We're going to pay for their salary. We're going to pay for their benefits. We're going to pay for their incentive program. but they're going to be a staff member that's going to be approved by the leadership of the community health center. They're going to interview them after we send them somebody that we believe is good for their, that's a good mix from their community. We're going to hire somebody from their area that has the expertise to work with them, and it's going to be part of their staff, and will stay there and remain with them. So we're going to provide them a staffing person. Revenue. One of the things we will then do is we're going to start to link health centers together to work together. Health centers are very independent animals. They're all community or rural health centers, and they all belong to the association, and they all go to the regional and national meetings. But as a group, they work very independently, almost like independent hospital systems do, and they don't cross over. But when we start to link them together through research, suddenly we're going to create a research cohort, and health centers take care of, somewhere 35 to 40 million people go to health centers. So all of a sudden we have a research cohort of 40 million people. So, even though Mr. Kennedy and the president just came out and said, oh, Harvard came out with a study on Tylenol, and this is what's causing autism. Well, they looked at 1,000 people. We can say, let's have the health center cohort look at this. We have 1 million women that have had children that have autism. Did they all take Tylenol? We have 3 million women that have delivered children that don't have autism. What did autism? Did they take Tylenol? We can look at things from a real perspective, not 1,000 people and extrapolate, but from 1 million people, and not have to extrapolate and say this is the reality of what's going on in diabetes. This is the reality of what's going on with autism. This is the reality of what's going on with hypertension. And suddenly we have a national research cohort that's manned by the community health centers, that's overseen by the state primary care associations and the national association, that we can give real data and real information to Health and Human Services to make real decisions about what has to happen with healthcare. So that's my pet rationale for doing this, is that we can create something that would be very meaningful to healthcare, moving the country forward, to taking care of people. And the last thing is that we're going to do is create an association of research with all the health centers, but then also enroll them into the National Society of Clinical Research, so that they can talk to other organizations that are doing research to make sure that they stay current with the current trends nationally, that they're not falling into a clique of health centers and not falling behind like health centers and rural health centers and the community health centers often do, because they're not current with the current trends and information that they're getting that information. So they're all the things that we're doing, and it's going to be a no cost to the health centers. With the funding, the way that it works from the pharmaceutical companies, they provide a startup fee, and then they pay you every quarter or every third through the whole trial, which allows you to sustain the staffing, allows you to sustain all the infrastructure that we need to do what they do. And they provide everything that the health centers will need as sites. So, the sites, once we get them involved, within 6 months, the whole program becomes self-sufficient because the system works. Pharmaceutical industry is not getting smaller. It's expected to grow by 12% over the next 10 years. So the number of pharmaceutical trials is going to not decrease, but it increase. And right now they do 1,000 primary care trials a year. Well, we don't need 1,000 primary care trials to have all the health centers doing trials, because if you have to put 40,000 patients into a trial for the drug to be approved by the FDA, that's a lot of health centers doing studies, and it's not a lot of patients per health center because they're limited. The FDA only allows a site to do, maybe 10 patients, maybe 15 patients. So we're not, if a health center has 10,000 patients or 7,500 patients, 10 patients in a diabetic study isn't even touching the number of patients. It's not a big burden upon the health center to be participating in a process that could bring millions of dollars into their bottom line.
Yeah. Well, I could say a couple things.
Sure, go ahead.
to kind of wrap up what I heard, because it's obvious like you have a lot of passion in this area, you know this area well, and I hear a lot of kind of themes that I'd say are kind of an all around win for community health centers, for for the pharmacy industry, potentially for government as well, who's looking at ways to, as you said, in the new administration and in prior administrations, how can we leverage kind of the investments and capabilities of commercial industry in healthcare when it comes to securing and helping the safety net population. And one way is through redistributions. The other is, and I really find this idea very innovative, although, to your point, you thought of it 30 years ago when you were doing this, but it's a fantastic idea that balances a lot of different interests across a lot of different, I think, policy and political perspectives. Why? I guess the question I have is, given that it does have so much potential, why isn't it commonplace now? You pointed out the reasons that came out from the National Association for Community Health Centers study. What are you seeing kind of holding people back from working with you on this? Or is it more just getting to those people, and once they hear this, then they understand like, hey, this is something we could do?
It's twofold. One, it's getting to them and having them hear it. And two is what I was talking about a little bit earlier about their box nice and tidy. And it's not something that, well, that's not something we do. Is one of the things that we were just at the Primary Care Association meeting in Pennsylvania, and people would walk up and say, "Oh, research," and they wouldn't even talk to us because it was. Yeah, I mean, it's without hearing why research, and then you get people to talk to you. Well, that's not something we do, and I would say, well, wait, here, read this. This is the National Association wrote this 2 years ago. That says that you should be doing. Oh, really? And then once they start to listen and they understand, and you have a lot of board members that say, "Oh, Tuskegee, you're going to abuse our patients," and we're going, and it's not that way anymore. The FDA has oversight. You have to have an independent review board doing oversight, and that's the reason we're creating our quality assurance, satisfaction, and the quality program is to have oversight on the local community health center level with the state associations and NAC helping supervise that oversight. It's with us. And I explained it. Well, you're just a CRO. Well, no, I'm not a clinical research organization. I have nothing to do with the pharmaceutical industry. I just want them to provide the opportunity for health centers to become research sites so that they can obtain the revenue to become sustainable. I'm from the movement. I've been a CEO. I've been a CMO. I've worked for the Bureau of Primary Healthcare. I don't care about what drugs the pharmaceutical industry goes. All I care about is having the ability to provide sites that are going to balance out the level of research, to have the right number of patients from each of the different demographics to make a drug show that it works for all populations, not just for single populations. And I want to make sure that the safety net is sustained. And this is a way to allow the safety net to be sustained in a way that is easily integratable into what the mission already is of community and rural health centers. So that's where I'm coming from. And that's what I say to them. I've written a paper that we give to people. It says CHROC versus CRO. Because, one of the first times we met with the National Association of Community Health Centers, one of the gentlemen from NAC kept saying, well, you're a CRO. And finally, after about 20 minutes, I said, please, let me say to you, I am not a CRO. And I went into all the reasons why we are not a CRO. We are not working for the pharmaceutical industry. We are not an arm of the pharmaceutical industry. We are not being paid by the pharmaceutical industry. We are working for health centers, and we're putting up to 80% of the money back into the health center movement. We're only keeping what we need to sustain the program, to be able to make it easy for health centers to do this and get all the revenue back from it.
Dr. Thompson, that's why I wanted to have you on today too. After speaking with you and hearing your story a little bit, I think you're facing a couple of challenges in that. One, you're in an industry where there's been hundreds of thousands of vendors that have come in. Everybody's looking for a piece, and so you're a good Samaritan in a sea of folks that are trying to be successful and profitable in healthcare, which is there's nothing wrong with that, but there's only so many pieces that can be divvied out before one of these health centers is made incomplete. So there's that, and you're also I think some of the feedback that I've gotten with clinical research in the past has been around, hey, I'm shelling out a lot of employees to do the clinical research or to tackle all the tasks associated with it. The return on my investment of my employees' time has not been
as high
as high as I had hoped, or beneficial for the hospital itself. So I think your model itself fixes some of those problems, and by default, giving 80% back to the health center is actually creating a sustainable revenue stream. I'd leave you with this last question. And, I know every health center is different, but on average, do you think partnering with an organization like yours can offset the total loss or deficit that the 15% that a health system can expect to lose with the changes to Medicaid that we talked about in this conversation? Or are there other things that they'll need to leverage or adopt to make themselves whole?
Well, that's one of the questions that we get asked when we're talking to CEOs of health centers all the time, and the answer is yes. The answer is yes. If we put a coordinator into a health center, a coordinator can minimally do 6 clinical trials a year. And by doing 6 clinical trials a year, the Office of Budget Management has come out and said that a clinical site at a health center, be it either community or rural health, is going to lose, if they have a 10%, they're going to take the average. They're saying they're going to lose between 5 and 15% of their revenue. So let's take, if they say they took 10%, which was the average. So every site, so a rural health center may have on average 3 sites. So they're going to lose $550,000 per site a year. So that health center is going to lose $1.5 million a year, which is a big hit. And most of them don't have the financial wherewithal. They don't have $1.5 million sitting in the bank, just waiting to be spent because the government has cut back their funding. They don't have that. So by doing the minimum of 6 trials a year with us, we can exceed that $1.5 million for them by giving them back 80% of the funds. Because by what will happen as we have more health centers become part of the program, our negotiating power increases. So instead of a pharmaceutical company or a CRO having to go to 100 different people and negotiating 100 different contracts, negotiating 100 different budgets, they can come to us and get 100 sites to take care of 10,000 1,000 patients, or come to us and get 1,000 sites and take care of 10,000 patients for their study. And we can negotiate one contract, one budget, and they don't have to do it 1,000 times. They can do it one time. So the economics of their savings just by working with us is incredible. So it becomes a benefit to the pharmaceutical companies. It helps them meet the FDA's requirements for diversity within studies. It provides a sustainable revenue source because the pharmaceutical industry isn't going anywhere. So if health centers are doing this every year, and they become very good at it, it becomes part of their daily operations. Within 2 or 3 weeks, my experience has been the coordinators become part of the staff. They're having lunch with everybody. They're joking around. The doctors all know them. They learn about these trials. Once patients have started doing trials, they talk to each other. Oh, you were in a trial? Yeah, it's easy. You just go, you get your medication just like you do. Normally you take your medicine. They call you every day, or you come in with a regular visit. You have your and patients start talking positively about about research, and the staff becomes comfortable with the research, and it's second nature to them after 3 or 4 weeks. And within a couple of months, everybody is having a positive experience from the research. Now says, "Wow, this is nothing like we thought it was," and all of a sudden, we're now having more staff. We've expanded our addiction services. We've expanded our behavioral health services. We've expanded our medical practices. We're adding a pharmacy to our program because we have the money now. We've added a second dental chair or a third dental chair because we have the money to do that. And as part of the process of doing research, you get new equipment. And after you've had the equipment for 6 months to a year, many times they don't want it back. So now you've gotten a new EKG machine, you've gotten a new spirometer, you've gotten a new tilt table, you've gotten new blood pressure cuffs, you've gotten new centrifuge, you've gotten a new freezer, all for your health center that you wouldn't have ever had the opportunity to buy, and you've been using the same EKG machine or spirometer for 20 years because you haven't had the opportunity to spend $1,000 on a new machine because you need to pay for an MA, or you need to pay for some supplies that you otherwise wouldn't have. So the benefits overall are just innumerable, and it's just and it's easy. Like I said, it's for doing a study, you need 10 patients. So you say, well, you need 10 diabetic patients. Well, it's easy to find 10 diabetic patients that come to their visits, that are compliant with what you tell them to do. And we're not looking for 1,000 patients or 500 patients. You're looking for 10. And then and if you do a hypertension study, a diabetic study, an obesity study, well, that's 30 patients, and all of a sudden you've made $750,000 from 30 patients,
Nice
and
paycheck.
and you've got new equipment, and you've had your doctor. You were a high enroller, and your doctor's been asked to co-author a paper, and your doctor's been asked to go and do a presentation in London on the new medication. And suddenly your health center is in a national journal, and is in a national at an international conference, having been a site that helped make this medication come to market. So it's amazing, the reputation, the innovation, all the things that can benefit a small health center just because they had the right patients, and they did a good job of taking care of their patients. This is to provide better care and to provide innovation to care and to bring sustainability to the care of those that are underserved and underinsured.
So, Dr. Thompson, thanks for coming on today and, talking about the $50 billion rural health transformation and sharing your thoughts there, but also sharing some ways that these rural health centers can sustain themselves and maybe create a new revenue stream to help prop themselves up against some of the changes in Medicaid that we discussed. But for a health center administrator or someone in our audience who may be listening to this and wants to get in touch with you or learn a little bit more, what's the best way to learn more, to get in touch with you, Dr. Thompson?
Well, you can go to our website. It's www.chrscorp.com. There's a link for information on the website. You can reach out to us via email. My email is vjthompsonmd@chrscorp.com. Probably the two best ways to reach out to us. We're also on LinkedIn. You can find myself. You can find my Chief Operating Officer, Dr. Johan Cruz Polanco. You can find our community outreach director, Jessica Jefferson, all on LinkedIn. You can find our page for Community Health Clinical Research Corporation, all on there. So Vincent J. Thompson, MD, is my LinkedIn page. Jessica Jefferson is our community outreach director. She'll be happy to talk with anybody about it, as well as my Chief Operating Officer, Dr. Johan Cruz Polanco. All three of us are very well versed in all the things that we spoke about today, and we'll be happy to speak with anyone. We're going to be also at several of the state association meetings. We'll be at the Chicanes meeting next week. We'll be at the Bi-States meeting the week after that. We'll be at the California Primary Care Association meeting, and we'll be in November, we'll be at the National Association of Community Health Centers Partners meeting in Minneapolis. So those are all opportunities to reach out and meet with us, and we'll be happy to talk with anyone. Please reach out. It's never an inconvenience. Email us, reach out to us on LinkedIn. I try to get to everyone. Myself, Johan, and Jessica, we try to answer everyone the same day that they reach out to us. Sometimes last night I had 4 inquiries after dinner, and I was writing letters back to them till about 10 o'clock at night. We're very motivated, we're very mission driven, and we're very engaged. We believe in what we're doing, and we know it's important. And right now, it's very important. Our goal is to get health centers to become enrolled and involved now before they start losing money from the Medicaid cuts in the beginning of next year. It takes about 90 days to get up and rolling and have your first trial. So if you start now, by the beginning of January, you're starting to see money coming in before the money starts disappearing from the 15% that you're going to lose. So it's important. We're very engaged and we're very motivated to get people to enroll now while it's timely and while they don't have to worry about not having the dollars coming in. If all of a sudden in March, 4,000 health centers decide they want to do this, well, it's going to be more challenging for us to get 4,000 health centers as opposed to starting now and rolling people in on a gradual basis, a couple every day and several every week and several every month. And we can get a number of health centers enrolled and having revenue come in before it becomes urgent.
Well, you heard it here, folks. Don't wait till it's too late. Thank you again, Dr. Thompson, for being on. Thank you to my co-host, Mike, for being here today.
Yeah, it was great.
Thank you. This concludes another episode of the Next Orbit podcast. We'll see you on the next one.
Thank you.
The Next Orbit podcast requires more than a conversation. It takes action, research, and collective wisdom. If today's episode resonated with you, we'd love to hear your insights. Join the conversation and help us shape the future together. We'll be back with more stories, strategies, and real-world solutions that are making a difference. In the meantime, be sure to subscribe, write a review, and share it with someone you think would benefit. Thanks for listening, and we'll see you on the next episode.